All right, good afternoon. Calling this meeting of the VEHI Board of Directors to order. It is 3:32 on April 17th. First item is I'm sorry, we're scheduled for 2 hours. First order of business is to review and adopt the agenda. Any comments on the agenda? I do have one item. We do have one item that came up after Bobby Joe sent the agenda, which is starting a discussion on GLP-1s and our coverage of them. So I know that this was brought up at our last board meeting, and we just forgot in the planning to add it into the agenda. So I would love to take a motion to add 15 minutes to discuss GLP-1 coverage.
I saw Cheryl say so moved, but I didn't hear.
I didn't hear. Sorry, I didn't hear.
So moved.
All right, Cheryl is made the motion. Lance second. Any discussion? All in favor, say aye.
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 Opposed? Passes unanimously. Bobby Joe, you have any, or where should we put it? Why don't we put it at the end? Okay. Any other discussions about the agenda? Motion to approve the amended agenda. Thank you, Lisa. Second.
Second.
Cheryl, thank you. All in favor, say aye. Aye. Opposed?
Aye.
None. Motion passes unanimously. All right, second item is public comment. No members of the public are on. We'll move on to item 3, discuss the update on legislative issues, specifically around the reference-based pricing. This is 30 minutes, and the ask was specifically for you, Mark. Talk to us about with the proposal for VEHI to pilot reference-based pricing. What does that mean for VEHI so that the board can start to move forward with making a decision about what our position is on that?
Sure. So good afternoon, all. I sent you a copy of the draft language, and I hope you've had an opportunity to read it and reflect on it. The language at present, as I said in my email, does not yet nest within an existing bill, nor is it a standalone bill. It is literally a proposal. So the component elements of the proposal are pretty straightforward, I think. It would mandate that the state begin moving toward reference-based pricing effective January 1 of 2026 by establishing a public sector pilot program, similar to what Montana did for the state employees, what Oregon has done or is doing for 300,000 public sector workers. States of South Carolina and Oklahoma have recently done the same. Indiana is proposing to do it this session in their legislature, and so is the state of Washington. So we would be following in some footsteps and leading in others. The two entities that would be impacted immediately would be school employees, licensed and non-licensed, active and retired, who are covered by VEHI, and the state employees or state employees who are part of the state of Vermont's medical fund. AFSCME, the other union that's implicated in collective bargaining and has school employees, but also most of its membership is in the municipal sector. Conceivably, they could be part of this proposal if the legislature saw fit, but at present, they are not in the language. The bill would mandate that for inpatient and outpatient services in network, the parties affected, again, VEHI and the state employees medical fund, would pay no more than 200% of Medicare rates, or excuse me, the lesser of or no more than 200% of Medicare rates. And for hospitals that might choose to jump ship and go out of network at some point in the future, and at present, There are no hospitals out of the Blue Cross network. But should some hospital choose to do that, their reimbursements for inpatient and outpatient services and products would be at 185% of Medicare, or the lesser of the negotiated rate that currently stands, or 185% of Medicare. So that's the sort of mathematical portion of the bill. It would only impact what are known as PPS hospitals, prospective payment hospitals. These are hospitals that have prospective payment methodologies and systems with the Centers for Medicare and Medicaid Services. That would be UVMMC, of course, Central Vermont, Rutland, Southwestern, Northwestern, and Brattleboro, 6 hospitals. This proposal would carve out the critical access hospitals in its initial run. The parties, the state of Vermont and VEHI, would direct their third-party administrators. In this case, for both entities, that would be Blue Cross Blue Shield of Vermont. Blue Cross is not specifically named in the proposal because at some future point, one or both parties may have a different TPA. We have, for example, talked about the possibility of going out for an RFP. So if this bill passed this session, then obviously the TPA would be Blue Cross. And we would direct our TPA and or a medical repricer. There are entities in the country that do this for states and large employers who have a lot of experience with the pricing system and the rules of Medicare, who are also capable of setting up systems for making sure hospitals are reimbursed no more than the terms that are in the proposal. So we could go with our TPA, we could go with a Medicare repricer, or we could go with both together, depending on what we think is most advantageous. The trust administrators of both pools, VEHI and the state of Vermont, could choose to work together in terms of helping to structure this with their TPA or with a Medicare repricer or both, or they could choose to go their separate paths. One of the benefits of working together when you've got 59,000 covered lives rather than approximately 35,000 in our case and approximately 25,000 in the state's case, you can often drive a better bargain in terms of purchasing services and also sending a clear message that the public sector takes this very seriously. The pricing limits in the bill would apply only to active members and retired members who are not yet enrolled in Medicare. And finally, the state of Vermont and VEHI on an annual basis, it could be on a different timeline as well, would audit the hospitals to make sure that they are paying claims in conformance with this proposal. We know that the University of Vermont Medical Center has violated its budget order 2 years in a row, 2023 and 2024, and Blue Cross believes it did not honor the unit cost percentages or factors that were negotiated between the two for FY22. This has been the subject of the recent settlement that was announced between the Green Mountain Care Board and UVMMC. At any rate, what I've learned by looking at what other states are doing is that they routinely audit these systems to make sure they're functioning the way the law would dictate them to function and to make sure that we're getting the very best deal that we can. The bill prohibits balance billing. So whatever a hospital is not getting in reimbursement that it used to get above, let's say, 200% of Medicare, it could not then pass on that cost to a school employee or to a family or to anyone else for that matter. And regardless of the payment systems that a hospital uses, value-based, capitation, fee-for-service, these pricing limits would still apply. And any premium rates that would be positively affected by this law would be secured by the parties. That is, that school districts, school employees, taxpayers would see the benefit of this law. Again, it is not yet a law. It is not yet even a bill, and it does not yet have a place in any existing legislation that is currently being debated. And finally, just to reiterate, we are hardly the first out of the gate with such a proposal. what surprised me recently, and you'll find reference to it in my most recent quarterly report, is that the state of Indiana has a bill being moved very aggressively by their governor and also by an employers forum, employers health insurance forum, a little bit like VEHI, only larger, that would strip hospitals of Indiana of their nonprofit status if they overcharged or charged over 200% of Medicare rates. So we're beginning to see a number of states address the rate setting problem with hospitals by using a benchmark to Medicare. Started with Montana in 2017, but it certainly didn't end there. So I'll stop there and happy to take any questions or comments. Andy? Oh, I'm sorry, Mike. I didn't mean to jump in.
Yeah, I'm sorry. Before we get to questions, I personally, I was looking for, I appreciate walking through what the bill says. And that's more about what the outcome would be. I was hoping to hear, what does this mean for VEHI? What would this mean in terms of our responsibility, money, efforts, accountability? What would this do to VEHI as an organization?
Okay, so when I was talking about our TPA or Medicare repricer, in order to, if you will, implement and enforce this law, whenever the state legislature sets in motion any kind of healthcare reform, it usually falls to commercial insurers or ASOs to implement it. So if the state removes a copay for a particular service, it's incumbent on Blue Cross and MVP to make sure that's the case. Or if an ASO is managing its services on its own, it would also have that responsibility. So if the legislature said to the 6 PPS hospitals, you shall be reimbursed at no greater than the lower of current cost or 200% of Medicare, we would say to Blue Cross, our TPA, this is what we expect you to implement and enforce on our behalf. At present, Blue Cross is the entity that negotiates unit cost for services and products with hospitals. And that's generally done by taking a discount off of the hospital's charge master. The charge master is the compendium of costs. They're mammoth documents, if you've ever seen one, for every service, product, and supply. And all of that would be implicated with this proposal. So Blue Cross today negotiates a discount, by and large, for most services and products off of the charge master. In this case, they wouldn't have to negotiate a discount off the charge master for each of these services. They would operate in terms of reimbursement on our behalf, or in tandem with a Medicare repricer, if we chose to hire one, to make sure that the terms of this law are enforced. So we've got a service agreement with Blue Cross of Vermont. That service agreement would go forward just as it does today, but with the terms of this law codified in it. And Blue Cross understanding that that would be its obligation to enforce these pricing limits. If we decided to hire a Medicare repricer in coordination with Blue Cross or separately from Blue Cross, that would be an additional expense that VEHI would incur. The other change, not potentially, would be the auditing process. So Blue Cross and the state of Vermont would audit to make sure the law is being enforced, or that our service agreements being enforced consistent with these pricing limits. Other than that, I don't think there's any major changes for VEHI on a day-to-day basis with respect to how we manage our program. And the benefits, of course, would be literally tens of millions of dollars in savings by benchmarking to Medicare. Does that answer your question, Mike? I mean, obviously, the management team, of course, would be involved with making sure the service agreement with Blue Cross was consistent with the terms of the law, just like we negotiate the terms of the service agreement today. If there was a Medicare repricer, that certainly would also be part of our duties. If we were working with the state of Vermont in some capacity, to make sure we were getting a really good deal on an audit, for example. That would also be part of our duties. Other than that, I don't think there's any major changes that I can think of.
Okay. Right, I'll open it up for questions, comments. Andrew, I think you had raised your hand.
Yeah, Mark, I was just curious. A lot of folks who work in my district and up and down along the Connecticut River, like live in New Hampshire. And so would this have any effect on them, like accessing healthcare in New Hampshire?
That's a great question. Dartmouth is not one of our Vermont PPS hospitals. As you noticed, that wasn't in the list that I gave you. And Dartmouth exists outside of the regulatory framework of Vermont. The Green Mountain Care Board doesn't have regulatory authority over a hospital in New Hampshire. So New Hampshire would be under no obligation to implement the terms of this proposal. Your employees and their family members, if they chose to go to another Vermont PPS, a Vermont PPS hospital rather than Dartmouth, would of course see the benefits of that. Yesterday, though, I was listening to Chris Whaley, he's someone I've been working with on and off for the past couple of years. Chris was formerly employed by RAND as a national analyst who carries a great deal of respect in his field. He works today for the Center for Healthcare Research. What's that? Center for Advancing Healthcare Policy through Research. It's based at Brown University. And he testified on reference-based pricing yesterday to the House Healthcare Committee. It's about a half-hour presentation. It went very well. Good discussion. And he reminded me of something that I'd forgotten. He said when California first implemented reference-based pricing, this would have been about a decade ago, and they did it differently than this. But he said what they discovered is that even hospitals that weren't not impacted by it, insurance carriers found that when they went to negotiate rates with those hospitals, it gave them more leverage in negotiations. And some of the hospitals were then more willing to either enter into agreements consistent with the reference-based pricing terms that California had implemented with other hospitals. So it's possible that if we succeed in Vermont with our 6 PPS, Blue Cross might be able, with more gravitas, if you will, to go to Dartmouth and say, you know what? You all need to do a little bit better on your unit costs because our 6 PPS hospitals here in Vermont, they're now at a lower rate. We'd like to see you get closer to that, or at least get closer to it. So potentially down the road, we could see an impact on a Dartmouth or perhaps other hospitals in New Hampshire, maybe even on the borderlands with New York or Massachusetts. But most immediately, it's going to be those 6 PPS hospitals.
Suzanne?
So my question, Mark, would be understanding everything you said and the fact that there's been some testimony. What do you foresee in terms of a timeline of this even being looked at by anybody at the legislative level?
Right now, the House Healthcare Committee is taking testimony on S-126. That's the big omnibus healthcare reform bill that came out of Senator Lyons' Senate Health and Welfare Committee about a month ago. And it was our hope then that this language or some version of it would be in that bill. We simply ran out of time and couldn't get it in, or the committee ran out of time. So the House Healthcare Committee is continuing to take testimony on reference-based pricing because in Senator Lyons' bill, there is specific reference to reference-based pricing in the context of the Green Mountain Care Board. The Green Mountain Care Board wants to begin implementing reference-based pricing in a kind of modest, incremental fashion, I believe beginning with this upcoming hospital budget cycle, and then build on that foundation to begin establishing global budgets for 6 hospitals in 2027 and the rest of our hospital system in 2030, with those global budgets being pegged to actual cost of operation rather than just building on revenue from year to year. So that's a very promising development. The committee has been asking questions of people like Chris Whaley about what if we did a public sector first approach? What do you think of that? They've received testimony from others as well. Marilyn Bartlett, Margaret Issa Smith from Oregon, myself, Adam Norton from VSEA. I said to someone today that our legislature has heard from some of the finest analysts in the country on reference-based pricing, and it's all been really positive. But at the moment, I don't see the proposal moving. It could. We all know that at the last minute, things can change in the legislature. Obviously, the legislature is really concerned about property taxes and healthcare costs, as they should be. So it's possible the committee may change direction and ask for testimony on this proposal or incorporate it, but I have not seen an indication of that as yet. So if it doesn't move this session, it's our intention, the two unions, to continue to pursue it at the next session. And if that does happen, it doesn't move, we're going to be watching closely to make sure the reference-based pricing language and S-126 isn't eroded or compromised in any way.
Cheryl?
Thank you. Let's see.
Cheryl, I'm sorry, I'm having trouble hearing you.
Okay, let me speak up. Can you hear me better now?
That's better, thank you.
Okay, sorry. My speaker's not very good on this laptop. So is the state of Vermont at this ready to sign on to this?
No, as I just said, there's the state of Vermont. I'm sorry. The state of Vermont supports it.
State of Vermont on your
Yes.
draft language.
I'm sorry, I was thinking of the legislature when you said state of Vermont. When you're talking about the state of Vermont Human Resources Division, Governor Scott's administration, the Human Resource Division at the state of Vermont is supportive of reference-based pricing, as we've explained it. So yes, they are supportive of it. Blue Cross is supportive of it, and the Green Mountain Care Board is supportive of it. The policy initiatives, though, that are needed to bring this to fruition, they'll really rest at the legislature at this point in time. So that's where it stands.
I also feel like I haven't, being a numbers person,
Sure.
I haven't really seen the numbers. I mean, we keep talking about this amount of savings. How do we derive that? I would really like to see some numbers about, you know, if it's this many hospitals, if it's this percentage, you know, what does that look like? We've not really seen any numbers and any modeling on this. And I really feel like that's missing in terms of decision making on this.
So what you have in your
We're at
possession.
too high a level. I want
No, that's
more
your question.
granular.
Your question's fine, and it's a important question.
Ooh.
So what I have provided to the board and to the management team is the Green Mountain Care Board analysis of December 16th, 2024. And I also provided a summary of the major findings of that analysis, which established the prospective cost savings of moving to 200% of Medicare. That's a long analysis. It's got a lot of really good numbers in it. The analysis was conducted under the auspices of the Green Mountain Care Board, but using a national vendor who has experience benchmarking to Medicare. So what that analysis showed is that over a 5-year period, 2018 through the first 3 quarters of 2023, had Vermont NEA, excuse me, not Vermont NEA, had VEHI and VSEA, or the state of Vermont, been reimbursing hospitals at no more than 200% of Medicare during the period of the study, we would have saved $400 million. Of that, roughly 60% of that, 58% or give or take, is VEHI's portion. About $230 million of the $400 million is VEHI's portion of that. We have a much higher concentration of members in the Burlington or greater Burlington area and in Chittenden County, which means we have more members than the state of Vermont who are getting care at the University of Vermont Medical Center. And UVMMC has some of the highest prices in the country. It's in the top decile in terms of its outpatient charges. So not surprisingly, of that $400 million in savings, the largest portion of it would be accruing to VEHI. So what I would recommend, and I'm happy at another point in time with the board to review that Green Mountain Care Board analysis with you. We can go over it together. We can look at the numbers, and we can talk about the potential savings for VEHI in the immediate future. The other thing that's interesting about the analysis is that in the first 3 quarters of 2023, according to the analysis, we were reimbursing the hospitals in Vermont at 326% of Medicare, right? Well over 3 times what Medicare reimburses. In 2022, the last full year for which we have data in the study, we were reimbursing, I believe, at 316 or 306% of Medicare. Now, remember
Hey,
that
I'm sorry to interrupt, Mark, but we've got like minutes left.
Sure.
I
Yeah.
see some other
And I
hands that are
do,
raised.
so I appreciate your willingness to go through that analysis, but really what I would really prefer is kind of extracting that analysis really for VEHI, and really focusing on VEHI as opposed to the whole study, you know, if that's possible. I would be interested in Bobby, Joe, and John's perspective on what the burden would be on VEHI as well, for implementing this. I would be interested in costs of the Medicare repricing vendor, the cost of audits, and, you know, time and effort in negotiating these things. And also, in addition, I would like to understand on your summary of the states that have implemented this, when they implemented it, whether it still is in place, you know, when they started, is it still in place? Has it ended? And are we talking about entire states that implemented this in the states that you identified, or is it pools that did it similar to us? That wasn't clear to me on that analysis that you gave us. So looking for some more information.
Yeah, I'll just answer your last question, and then we obviously need to move on. But the state of Washington is now actively trying to secure legislation to do it for the state, for its public sector, 700,000 lives. Colorado did it as a state for its exchange plans. Nevada is moving to it in 2026 as a state, I believe, again, for its exchange plans. Oregon is doing it currently as a state for 300,000 public sector workers, including school employees. South Carolina and Oklahoma have moved recently as states to do it for their public sectors. So they are state initiatives impacting public sector employees or public sector pools.
So if you could add that information to this, to what you provided us, that would be helpful as opposed to just reciting it. That'd be great. Thank you.
Bobby, Joe, you had raised your hand.
That's okay. Well, we can just go ahead. Thank you though.
I don't see anybody else with their hands raised. Mark, I do want to bring up a sensitive topic, which is the fact that is your role in moving reference-based pricing forward. So you obviously have been a big advocate. And you're working and you have different hats, right? You're paid for 80% of your salary is for the VEHI contract and 20% comes from the Vermont.
Actually, it's 85% of my salary.
85 and 15. Okay. Can you talk to us a little bit about why the NEA made the proposal that VEHI be part of the pilot or lead the pilot before the VEHI board weighed in on it? And how you navigate wearing two hats for two different organizations?
The navigation problem, I don't find to be a problem, or at least the fear of a problem, because Vermont NEA, and me in particular, have always been focused on healthcare reforms that will actually lower costs, lower prices. To the extent we are successful at doing that, we impact positively school districts and school employees. The reference-based pricing project, literally, Mike, has tens of millions of dollars in savings on the table. That would tremendously help VEHI. It will help school boards, and it will help school employees. So I don't see any contradiction between advancing reforms that I know are working in other states and in the public sector, and fulfilling my duties as a trust administrator. When I advanced to VEHI the idea of hiring Remedy, that was my proposal. And I did so after a lot of research because I believed it would have a direct impact on our ability to control RX prices. As wild as they are, it would give us a little bit more leverage in that domain. So that was another reform initiative that played out well, I think, for us. And I think reference-based pricing is the same thing, only on a vaster scale and with substantially more and sustainable savings with respect to premiums. And so
I'm not going to argue about the potential impact, positive impact. My concern is with that example you gave for Remedy, you brought it to the VEHI board, and the VEHI board was the one who said, okay, we're going to deliberate and make a decision. In the case of the RBP pilot, it appears to me that you worked with the NEA to bring it to the legislature, and you didn't bring it to the VEHI board.
well, I guess what I'd say is I first brought reference-based pricing to the attention of Bobby, Joe, and John in 2021. It's been a 4-year run for me. And I have talked about reference-based pricing, probably till you guys are tired of hearing about it. And I've written about it pretty extensively in my quarterly reports. And I also said in those reports that Vermont NEA and VSEA would be moving forward with this in the legislature, and that we'd be moving forward prior to that with the Green Mountain Care Board to do the study. So I don't think anything I've done was secretive or should have been a surprise to anyone. And the analysis was just so affirming of what I had learned from other states that were doing this in the public sector, that it seemed to make really good sense to continue forward, as I said I would in my written reports. And I will say, and this is a great disappointment to me, but there's no other way to put it, that analysis came out and no one asked to talk to me about it. No one. And it was the first of its kind in the state of Vermont. It enjoyed very strong support from the Green Mountain Care Board, still has strong support from our regulators. It enjoys the support of the Human Resources Department of the state of Vermont, and Blue Cross is not opposed to it. So it's just odd that I find myself always feeling like I'm on the outside looking in when it comes to reference-based pricing. We have this analysis in our lap that I spent considerable time making sure happened. And I wrote a summary of that analysis. And nothing, no response. And so for what it's worth, that's how it feels to be me in this situation right now. And nothing I've done, again, has been concealed or should have been a surprise. We said we were going to do this, and we didn't. And if we succeed, the benefits are immense. They're just immense, vastly greater than any savings we could have hoped for in any other domain as soon as January 1 or through, 2026. And that was my hope, because right now we're looking at a pretty dire situation, all of us in the health insurance market. And if we can get those kind of savings, it allows us to say to school districts, we're delivering value, and hopefully we can come in with a lower premium rate than we've been coming in with in the last few years. That was the objective, frankly.
Lance?
I thought we'd already discussed this, you know, and we sent a message to the legislature about this, that we wanted to be consulted whenever anything like this happens. Didn't we discuss this at the last meeting?
We did not discuss this. This happened, you and I had, did we discuss it as a board after we sent that letter?
Mhm.
Yeah,
Yeah, and that was a message to
Right.
the legislature.
right. It was a message to the legislature, but we talked about it at a board meeting. So I feel like we've already kind of discussed this, and I don't know why we're spending time on this. And I also feel that the conversation that I just heard kind of attacked Mark's integrity a little bit, and that doesn't make me feel good. I think that Mark does things with VEHI in mind. I think that because of his unique situation, a lot of the things that are going to be good for VEHI would be good for Vermont NEA within, you know, with the context that it is Vermont NEA has people that we're representing, people that we're trying to design healthcare plans for, trying to save them money, trying to give them good healthcare. So I didn't know that we were going to be having that conversation with Mark, and I wish that I would have been kind of tipped off on that so that I could have been prepared for that.
Lisa?
I guess my perspective about this is that every time reference-based pricing has been brought up, it's basically been stonewalled from my point of view. And all the positives have been reiterated on numerous occasions. We've been talking about this for a very long time. And I just don't see how VEHI is put in any harmful situation whatsoever in this case. I just don't see how we are in any way being harmed if our goal is high quality and cost efficiency. Regional reference-based pricing seems to do that more than any other. I mean, no other proposal, no other suggestion. I mean, Remedies has done a good job, but this one seems to hit at the heart of the problem that we're facing as an insurance, as a health insurer.
Bobby Joe?
So that's what has been brought up for the past 4 years, and repeatedly, John and I have said, show us how it'll work. We've said it needs to be done at the legislature, which is, you know, kind of where it's at right now, and that's where we hope it and think it belongs. It's never been something we wanted to take on as an organization to go up against all of the hospitals. We felt like there was it was kind of a fool's errand as a relatively large pool, but in a small state where hospital budgets are being asked to go up in the teens, how we would go in and demand lower prices. So we had asked for how could it be done? We think it should be done by the state, not at the VEHI level, to do the negotiations. And that's kind of where it's at right now, and that's where we hope that it continues to go. With regard to the savings that were, you know, Mark sent out the thing saying that if we paid all the hospitals a lower amount, we would save a bunch of money, which I think we all knew that was kind of what the answer would be. If you pay someone less than what they're asking for, you're going to save money overall. The $400 million quickly goes down from 400 million to 230 million, on average of 40 million. And then that was all of the hospitals, all of the services at 200% of Medicare. So that was, you know, the very best case scenario was somewhere in the 40 to $50 million range. But when you start peeling back that it's only 6 hospitals, or maybe it's only 3 hospitals. Mark even said the other day, maybe we could only get it with UVM. So now we're down to 1 hospital. Is it 200% of Medicare, or is it 250% of Medicare? So when you start modeling all of those out, it goes from tens of millions to hopefully 10 million. But we still don't know how much it costs, who's going to do it for us, what the return on investment is. So I think those are the numbers that Cheryl was looking for, is kind of, drill down. We keep talking about these, like 90 million's the number that's in the legislature right now that's being talked about. But it's not 90 million, it's going to come down a lot from that. So that's the kind of information we need before we can move forward.
So Mark, I know that you want to talk about some numbers, or I anticipate you want to talk about some numbers. My suggestion is, since we're a little over the time, we got some other subjects. Clearly the book, like, I know that I'm with Cheryl. I need some information in order to make an informed decision. I need some numbers and written things. So my proposal will be that we're going to come back for a May meeting, and we could take that time to look at those numbers, to look at that information that we asked for as a board. And then we can make some decisions about moving forward, or how we would move forward with reference-based pricing.
I would appreciate it if I could receive those questions well in advance of the meeting so that I'm fully prepared. Because as I said, I've not gotten any to date. And that analysis has been out there for 4 months. And I'm sorry, Mike, it's a little frustrating. And I want to thank Bobby Joe for reminding me that she and John did encourage me to go to the legislature, because they didn't feel like we could tackle RBP as a pool. I don't necessarily agree with that, but at least we did have the conversation, and the legislative approach did come up. And I do have a lot to say about Bobby Joe's summation of the numbers, but that's better left to another time.
Jonathan?
Sure, thanks. I was trying really hard not to get involved. I just wanted to answer, when Mark says we haven't asked any questions, that's just not true. I've been asking Mark for a long time to please tell me how this works in Vermont, how much can we save, show me the numbers, and I keep getting 400 million. I don't get, this is what VEHI will save in any given year based on the numbers. So it's disingenuous to say that I haven't asked Mark any questions at all.
Michael, I'm sorry, I need to respond to that. I'm sorry. When I said I haven't gotten any questions today, and I meant from the board, I have definitely gotten questions from Jonathan and Bobby Joe. And again, there has been no invitation to me by my colleagues to sit down and study that analysis by the Green Mountain Care Board, or my summary of it, or additional analyses that have been done since then. There are a lot of numbers out there, true. They're very compelling numbers, and it's very easy to talk about how this works in Vermont because it's laid out in the proposal and it's been done by other states. And I'm happy to have that conversation. Absolutely happy to have it. But in terms of what's coming in May, let me know what the board most wants to hear about. And finally, to Bobby Joe's last point, yeah, once this is in the legislative lap, or it's part of a bill, or it's a standalone, those numbers could change. Might not be 200, could be 215, 225. It might be 3 hospitals that then goes to 5, that then goes to 6. So we'll never know definitively when we have the conversation what that final number will be, but we can operate safely within a certain range. And it, again, is a significant amount of money that can be saved. But that's the kind of conversation I think we should have, and I'm more than welcome to have it. And what I can't answer, I'll dig for the answers. Thanks.
All right, unless there's somebody who's got something urgent to say, I think we'll go and move on. There's no action for the board to take, and then Lance and I will work with the management team to prep for next month and do a full presentation of reference-based pricing. Okay, next agenda item is benefit design and timeline. So we've got 40 minutes. Mark had wanted, we're gonna carve it out, Mark 20 minutes and Bobby Joe 20 minutes. So Mark, you ready to kick off?
Why don't you have Bobby Joe Stark? I think you wanted to see if board members had questions for her based on her presentation. That'll allow me to get a drink of water, if that's okay.
So one thing I added, Mark and I had a quick email conversation this morning about the presentation I had sent out. And one of the pieces that was on there was I had lumped together people who had no claims and people who paid zero. He wanted to see that broken out separately. So I can show you that slide real quick and I can resend it out. I don't have it for each individual segment, but I have it for the whole group. So just to kind of give you an idea of what I was referring to. So before, everything that was in kind of the dark pink, it might have been red before actually, we're showing as no claims and paid zero collapsed into one. So this separates them out to show that 3.7% overall. And again, these, I focused on the gold CDHP. So this is
Sorry,
everyone.
can you just put this in presentation mode? I got a small screen.
Oh, sorry, sure.
Yeah.
I will try. There we go.
Perfect, thank you.
Okay. So it's 3.7. And when we had done this a number of years ago, I think the last time we did it, Mark, was in 2016, and it was probably using 2015 data because we had it for use when we were going out and talking to folks about where where their spending was. And it was, he was thinking there was more closer to 8% of folks that had no services. And that's decreased to 3.7%. Not a huge surprise to me, honestly. A lot of preventive care people are getting, prescriptions, that would have to be, they got no prescriptions and no, and didn't even have a primary care office visit. So 3.7% of folks had zero, 45%, 45.7% had claims but didn't exceed their HRA. And then it goes on from there. So I just wanted to show that, and I can resend that out after.
So just before you go on, any questions on that chart? Can you bring that up again?
Sorry, yeah.
It's all right. Any questions on that? My question.
Okay. Well,
Yeah, go ahead.
Mike, I was just going to ask real quick, and if Bobby Joe, just let me check my thinking right. So the 45% are people who didn't exceed, but then as that goes up, that's just the number of people who cost that much more over their HRA. Is that?
So yeah, let me just say it back one more time. So the folks in red had zero claims. The folks in pink had, they had claims, but it didn't exceed their HRA amount. So they didn't have to pay anything for claims. They still had to pay their premium, but they didn't have to pay anything for claims. The light purple are folks that paid somewhere between a quarter, and there was literally one person that had a quarter, a quarter and $300. So, I won't go through that. The dark purple is they paid out of pocket between $301 and $600. And then that last column between $601 and $1,000 are folks who paid up to that amount. Now, the only people that would be eligible to pay between $601 and $1,000 would be licensed folks on a family plan. So there's only one segment of the four that would be in that grouping. And when I say family plan, just as a confirmation, because Mark had asked a question earlier, that includes anyone that's on a 2 or more plan because it automatically doubles the deductible. So I collapsed those 3 tiers into one. So it's anyone that's a 2-person with their spouse, a parent and child, or children, or a family plan. And they would have to be licensed in order to hit that amount.
And I'm sorry, and this is what they're paying out of pocket. Is there a cost then to VEHI because of that? I'm just trying to understand.
Yeah, there's actually.
What does this represent for VEHI?
Yeah, so for VEHI for sure. So anything above those numbers, VEHI is picking up. And there's a couple different things. So first of all, we always cover all preventive. So that includes things like the colonoscopies, the mammograms, preventive care, and we have 6 types of preventive medication, wellness medications that are covered at 100%. We automatically pay those. Anyone that goes above and is starting to pay something, VEHI is basically paying 4 times that, because in order for them to pay their 20%, VEHI has to pay the other 80%. So, yeah. I know it's a lot of information.
And what you're showing in terms of the out-of-pocket, that's not their total cost of healthcare because they are paying into their premium, right?
Mhm.
Okay.
Yeah, this is just looking at claims because just letting you know. Any other questions on that or anything else that was in that presentation? I wanted to give folks an opportunity to ask because I know we kind of ran out of time
Can you
last
bring
time.
Can you bring up this slide about where it shows how the HRA layers on top? This was towards the end.
Not this one?
I'm not seeing. I don't think you're not sharing.
Oh,
We're not
sorry.
seeing anything, Bobby Joe.
Oh, I'm sorry. I thought I was sharing.
Now we are. Well,
Apologize. I'm sorry. I was
There.
thinking you could see it the whole time.
Yeah, that's the one. So I think it's important. We were talking before the meeting about how we design plans and then how the commission comes along and does the, I don't know the right phrase, which is a cost sharing, right? And they've done that through the HRA, and that's their purview. So one of the things that I've been thinking about is what is the remit of VEHI versus what is the remit of the commission. So in terms of plan design, I think it's worth a quick discussion of what is our responsibility? Is it we're obviously designing the plans, but do we design them independent and ignore the fact that there's these HRAs layering on top? Do we take that into factor? Do we coordinate with the commission? Is that allowed? Like all of these factors, it's still not clear in my mind how we go about plan redesign when not all of the cost decisions are under our control. And I don't have a statement, but I think it's worth it. I want to hear from other board members about your thoughts and your questions around that. Suzanne?
So I think those are really good points, Mike, because and maybe this is a naive take on this, but my sense is it's always been the case that VEHI develops plans, even pre-commission, and local associations with the school boards bargained cost shares in lots of ways, premium splits. And even before the commission, we talked about ways that, first dollar, last dollar, there were a number of things that happened. So my unease about some of this is going to be that if we start, first of all, I think we have to be clear, as you said, what's our mission, what's in our wheelhouse, versus what's in the commission's wheelhouse. And then another layer that's really important for me is to say, okay, if we're going to do these redesigns or levers, do we have criteria that we want to weigh our decisions against? Do we have principles? What's our mission? And can we be really clear about those pieces? And if we are, then some of these other discussions might be a little bit easier, in my opinion.
Lance?
I think that like coordinating with the commission, we've talked about this before, and my opinion is that we're not involved in negotiations. And if we were to try to negotiations proof the plans, then we are, in fact, involving ourselves in the negotiations. I've never been involved with designing these plans before, and I'm looking forward to doing that work and looking forward to learning about it, about all the ways things have been done in the past. I know that in negotiations, where regardless of what the commission does, I know that the locals, when they negotiate with their local school boards, they do look at what the cost increases are And they do look at the percentages that the school board pays, and they look at the percentages that the working folks pay, and they'll get it back in salaries. That's what they do. That's what locals do, is they work on that. So as much as we may think that we can negotiation proof these plans, we're not going to be able to, not in a practical fashion. And I think that we should just stay right out of that realm, and we should focus on, trying to create healthcare plans that are going to save everyone money and have good healthcare for people.
One of the interesting things that happened in meeting not too long ago was that the commissioners came to us and they had two asks, right? They said, renegotiate with, go to RFP for Blue Cross Blue Shield, and we're going to talk about that in a bit. And they also said, update the plans, right? Get rid of the two that are not used as much. My thought is that I think my ask would be for the board to authorize that Lance and I have a conversation with the two commissioners and to clarify, I think, a potential misconception about what Blue Cross Blue Shield does for us, the fact that they are an ASO and we're not, that we are self-insured, and also to talk about plan redesign and make sure that what we're talking about here is their understanding that we're gonna work on a plan design that's right for VEHI, its members, and its financial stability, right? Because that's our responsibility as board members, and that they're going to layer on top, and they're responsible for the overall cost sharing and making sure that we're all aligned. So that was my thought for this meeting, is to make sure that, not that we are coordinating a full financial picture of what these plans would look like, but that it's very clear to the commissioners and to us who's doing what part of this complicated system. Cheryl?
Yeah, when I think about what we might consider in plan redesign, is how our plans compare to other plans. I know Bobby Joe gave us in this presentation an analysis of the premium sharing or cost sharing or AV values of the Vermont Health Connect plans compared to ours. And you can see how those compare to our plans. And it's not only that, it's sitting in really difficult public board meetings, listening to taxpayers who may or may not even have health insurance coverage, struggling to pay their property tax, and specifically their education tax bill, of which this plays into. So when I'm in those meetings and I am participating in those difficult conversations about whether or not we're going to cut buses for kids to be able to get places in order to pay for other things, I start to think about how these plans compare to those parents who are now going to have to deal with picking up their kids and getting them everywhere because the district can't pay for something that we've been able to pay for. And so I look at this in terms of trying to look at our plans in the picture of the rest of the state and what is happening in the rest of our state in terms of what people are paying for health insurance, and what is the employer share and what is the employee share, and how that plays out for our taxpayers. So I think that is valuable to look at, how we compare, how our plans compare at least to Vermont Health Connect, maybe how they compare to maybe another large employer in the state. And I agree with reducing the number of plans, whether or not that's really worthwhile. So that would be my thinking on how to approach this.
Jonathan?
Sure, I was just gonna say that, I think that it makes sense probably for Mike and Lance to go and talk to the chairs of the commission, because they came to this board and there's a question out there hanging. They said, hey, we want you to look at, bidding out the Blue Cross contract, and we want you to look at the plans. So it's almost like they're waiting for an answer from this board to come back, and it's not getting involved in negotiations. I see it as education. Like, here's why we took your suggestion, we talked about it, and here's what you need to know. We're an ASO, we insure ourselves. Here's what you need to know about the plans. We can develop plans that provide great healthcare, but what you do impacts that as well, and here's how. So it's more education to me.
Lisa?
I'm just curious about the timeline for this. Like, what are we talking, when are these new plans supposed to be, or would they be actually enacted or become part of the what's the timeline for this process?
A question for the board or for the management?
I think it's a question for when, and maybe it's a question for the commission. When do they want these plans, these new plans available?
Bobby Joe, can you speak to when we did this last time, how long it took?
When we changed the plans in 2018?
Yeah.
Yeah, I mean, we did like a 2-year runway. We started talking about it early. I mean, I think the reason why I brought the plan that I brought last month in order to get pricing was because people are, get at us like, how are you going to reduce costs? VEHI costs too much. VEHI. VEHI needs to, go see another vendor or whatever. So we were trying to pull the levers that we have the opportunity to pull. And as far as, making plan design changes, these are not things that are outside of the norm. I've been doing this for 30 years. And when rates go up, you start adjusting deductibles, you start adjusting copays. That's just the way the plans work. And it's like that no matter what type of insurance you're working with, whether it's dental or whether it's your homeowner's insurance. The first thing they say is, well, if you want a decrease in your rates, you really need to increase your deductible. So that's, because people were asking us for lower costs, that's why we came out with it. If we are looking to truly try and reduce costs and we want to do it quickly, we have to let Blue Cross know in order to turn this around. It would be difficult, I think, to do anything for 26. I think we'd be looking at 27. Right now, the commission's benefit is in place through 27. So now we're looking at 2028 before we could possibly see any cost savings based on plan design.
Mark?
Yeah, I was just going to add on to Bobby Joe's last comment about the timeline with respect to statewide bargaining. The current agreement is in force through 2027. That means we would probably roll out any new plan or plans effective January 1 of 2028. There may be some integration process here that I'm not thinking about, but January 1 of 2028 seems like a reasonable deadline to shoot for. There may be some, anyways, I think that's probably what we're looking at. And Bobby Joe's right. This is not, generally speaking, a quick process, and it shouldn't be. There's a lot of different factors that come into play. And as I'm going to suggest in a few moments, I want us to think differently about plan design this time than we have done in the past, and different than how commercial insurance carriers tend to think about it, which would add potentially more complexity and perhaps time to the process. But certainly it seems to me we could have something ready to run by January 1 of 2028. And we then need to think about how that intersects with the bargaining process. And maybe it doesn't intersect well. I don't know. But that's got to be a factor in our thinking as well.
Thank you, Mark. Bobby
So
Joe, do
I'll
you
just-
have an ask for the board?
I think it would be interesting to know what, well, let me say this first. So the reason that we're in the predicament that we're in with the bargaining and the commission is because we changed our plans and we had higher deductible plans and people felt like they couldn't afford them. They needed assistance with the cost shares. That's how and then, you know, things got screwed up with the initial rounds of bargaining. So that's how we ended up with, you know, the statewide bargaining. You know, what I've heard from a few folks, and I think Cheryl was in the meeting I was at last week, the folks said, you know, why don't we, instead of having these, you know, higher deductible plans, you know, complemented with an HRA, why don't we go back to the same type of plans that we've had in the past? So it would be interesting to review, you know, we're going to know what our next rate increase is going to be by September, October. We could look at the plan designs that we talked about last month that I showed you just to get an idea of what changing benefits can do to rates. And we can also ask for a quote, what if we just went back to the plan that we had in 2017? What would that look like? And it would remove, you know, if we went back to a plan design like we had before, it would really remove the need for an HRA. So, you know, those are things that I would ask that we research and that we ask Blue Cross to quote for us. Having that information to make decisions moving forward, I think would be beneficial. So I would ask that you would allow me to price out the two plans that I suggested, as well as let's go retro and look at our old plan and say, pull the HRAs out. Assume, you know, I know we can't tell them what to do, but assuming they wouldn't need an HRA, we went back to an old plan design, what would that look like premium wise?
What does that entail in terms of time and cost to price those out?
It costs nothing. Blue Cross will quote that for us. And I would suspect it would take them maybe a month, depending on their timeline, what they have that they're working on. You know, it doesn't lock us into anything. It just gives us information.
Cheryl?
It's an interesting thought because, I mean, districts are paying, you know, third-party administrator fees. Employees are paying fees to third-party administrators. And we need to have staff in order to administer the plans in our office. You know, the back office part of this, it's not of administering 4 different plans with HRAs, FSAs, HSAs, LPFSAs, takes a fair amount of back office time and effort. And it would be interesting to see what the other plans, the old plans that we had, how those would stack up. And I know we're going to be hearing from Mark, and I read through the information that he gave us, but I think plan design, in addition to the things that Mark has on his list, plan redesign needs to be on the list, because I think there are optics that we have to deal with in terms of that. And again, you know, Andy and I sit in public board meetings trying to navigate that, and it really difficult. I mean, thank God I was one of the few budgets that got voted down the first time. Thank goodness it passed on Tuesday. I'm very thankful for that I don't have to go through more public meetings to try to get this budget passed, but it's really hard. And so I think we have to be able to say that we're looking at all these things. I appreciate the efforts on reference-based pricing and remedy and all the other things that Mark is going to talk to us about. But I think plan redesign has to be in there and as well, Because actually, in some ways, plan redesign is what people see. Unfortunately, they don't see some of those other things that are happening in the background.
Thanks, Cheryl. Lisa?
This may not be relevant and I'm not sure. But in any case, I worked for a district for 30 years that had an HRA actually. I think it was one of the first districts to have it. And so what I'm hearing is likely to happen or could happen is you're basically saying, okay, VEHI is not going to deal with this and we're going to let them deal with it on the local level. And when that happens, what happens is that your poorer districts don't get as good a plan or a financial deal as the better. I mean, when the transition took place for somebody who worked for North Country for 30 years and negotiated for 20 plus, we were never on the same footing as the Burlington area and never expected to be. But we did introduce HRIs and there was an awful lot of work that took place on the local level. And it just, maybe I'm off base, but it seems to me like VEHI saying, oh, we don't want to deal with this. We're going to, you know, we'll let it go back to the local level. And
No,
we'll,
I don't mean get rid of the commission at all. What I'm saying is make it easier on the commission by, they don't have to worry about, you know, arguing over, you know, the 80-20, who pays how much of these large deductibles. And I'm not talking about the HR, I'm talking about like a Vermont Health Partnership Plan, a J plan, like one of the old original plans that were basically, you don't need an HRA because there are a handful of copays and that's it. So I was,
that's a long time ago. Just the, I mean, we had an HRA literally 20 years ago at North Country.
you were one of the very few, but
Yes,
Vermont Health
absolutely.
Partnership was the main plan for us up until 2017.
But I don't think that could happen as long as we had collective bargaining happening at the statewide level. It kind of takes that part of it out because it means that everybody is going to be cost sharing the same because that is all being bargained at the state level. I understand, Lisa, if when it was bargained at the district level, there were great disparities between, you know, what one district was paying versus what another district was paying. But with the statewide bargaining, that's out of there. So I don't think a district could do something like that. So.
Chris, yeah, sorry, I'm just going to move forward because we're already over time. Chris, do you have something?
Yes, very quickly. Just when you were talking about Bobby Joe was asking the board to authorize to go and price these plans and maybe looking at some of the old plans which had the copays. The only comment I wanted to make on that is that the copay would really need to be looked at for inflationary growth. We wouldn't want to go back and price a copay because $10 8 years ago is certainly not $10 today. So I would ask that if the board is interested in having some of those plans quoted, that we have the discretion to look at those copay levels and adjust them.
Andrew?
I'll try to be quick. My only comment is like the statewide bargaining and everything. And the fact of everyone wanting to have the exact same, no matter where you are in the state, is actually what's bankrupting the state because it can't be like I see it like if we had to pay the same teacher rate as what Burlington's making, I would have far less teachers in my district because my taxpayers couldn't handle it. And so every time this, you know, it's the biggest argument of around consolidation and everything is, you know, some districts want to have little schools and you know, it's costing more money to have that. And so as we talk about plans here and everything, if we're going to have a plan that everyone gets the exact same thing, it's going to cost a lot of money. And I think that's just something we have to always keep in our forefront.
All right, so thank you. We're gonna move on to Mark's segment and then I'm gonna ask for some motions at the end of it. So Mark, go ahead and talk
All right,
about.
I'm going to do the most challenging thing I have to do in my life, share a screen. Just give me a moment.
I can do do it, Mark, if you want. I have it out. Up to you.
Hold on for a sec.
I have faith you can do it, but I will do it if you need me to.
You shouldn't have faith. Ye of greater faith than me. Okay, hold on. Can you folks see anything? Yep.
Yep, we see PowerPoint.
Okay. How about this? Can you see that?
Yep, fourth generation.
Yes, excellent. All right. Hold on. All righty. So I cannot see you. So by all means, let me know when you have a question, or let Bobby Joe know and she can shout it out to me. I want to say first, I'm happy to take any questions on the written document that I sent you on actuarial value and high deductible health plans in the context of this presentation or later. I have not had a chance to do the empirical analysis with the data that Bobby Joe did for her presentation last month. I will do that when I get some breathing space. I always appreciate when people do research and they spend the kind of time that Bobby Joe must have spent days, if not weeks, preparing that. But I didn't see it until you did. And for me to embrace its conclusions or to ask even intelligent questions about it, I would need to do my own empirical analysis with or Bobby Joe's help perhaps at some point. But what I want to focus on today primarily is some of the underlying assumptions that are in that analysis, and also that really came up in this conversation today, and why it is at this point I'm opposed to costing anything out, past, present, or future, until we have a different way, until we conceive of a different way of thinking about benefit design. And I've titled this presentation The Fourth Generation of VEHI Benefit Design, and the reason for that will become clear in a moment. And I think what we're faced with in principle, morally, and organizationally is the question of whether or not we are going to continue to look at commercial insurance plans, and Bobby Joe already alluded to this today, as exercises in cost shifting by raising deductibles, co-pays, co-insurance, or we're actually going to do something in a very sort of bold or ambitious way to lower costs, not merely to shift them. And whether we're going to anchor this commitment, this effort, to greater affordability for employers and employees, or create more financial vulnerability for employers and employees. So as I read through Bobby Joe's presentation, 34 slides, again, very comprehensive, it struck me to be a direct critique of the cost-sharing terms under statewide bargaining. It was not about, or at least not directly about, benefit design. It was about cost-sharing in the context of bargaining, which is outside the scope of our mission. Nonetheless, I think what Bobby Joe is getting at in her presentation, and also in some comments she made today, and also to the negotiation commissioners when we first met with them, is that she clearly wants to see benefit plans with lower actuarial value. And to do this, it requires greater cost shifting of out-of-pocket charges to employees, and also, I should have said here, their families. And of course, as costs rise, these out-of-pocket costs need to be indexed by some formula to maintain a lower actuarial value. This is what's known in the business as benefit leveraging. And in essence, if you think about commercial insurance as a process where every time costs go up with respect to premiums, driven largely by prices and utilization, then you need to think about adjusting upward deductibles, co-pays, and co-insurance. That's the fundamental logic by which a lot of commercial insurance carriers have historically operated. And my conviction and my argument today is that that's a mistake going forward. And you never get off the treadmill of ever increasing costs. And to maintain lower AV value, you're going to have to shift those costs to employees. And the argument here historically has been, well, if you have higher OOP liabilities, higher out-of-pocket liabilities in the form of deductibles, copays, et cetera, you will somehow induce lower utilization, which in turn will result in lower costs, which will lead to lower premiums and presumably better care as patients become better shoppers of healthcare. This is commonly known as giving workers more skin in the game. And my applause to Bobby Joe for not using that term. But in essence, that's the logic that drives the thinking around lower AV value. There's only one reference in Bobby Joe's presentation to prices. It's the expression, the cost of services is an issue. My argument is that it's not an issue, it is the issue. And this is where I want to focus a lot of time today before I come to a recommendation about benefit design. So if patients are going to forego services because of higher out-of-pocket costs, and they do, then the question becomes, are these higher low-value services? And in fairness to Bobby Joe, she can't possibly know this, nor can actuaries, as it turns out. The actuarial factors, the Health and Human Service actuarial methodology that she alludes to in her presentation, cannot discern the difference between high and low-value services when patients forego those services because of cost. The methodology that actuaries use, sometimes it's HHS, sometimes it's Milliman. Blue Cross used to use Milliman. It will say, if you raise out-of-pocket costs, we estimate a certain percentage of services will not be received by patients, which in turn means less risk on your premium. But they cannot tell you, and I've asked this explicitly of the chief actuary of Blue Cross, whether that service that's been foregone was a high-value service that we'd want the patient to get, or a low-value service, essential or non-essential. Those methodologies, those actuarial factors, they can't tell you that. Actuarial value becomes a common metric when cost shifting is the primary objective. As I said in the written document I sent you, this factor has no bearing on the price of care. Whatever a service costs at UVMMC today, it's going to continue to cost until they raise the price or lower it, irrespective of actuarial value. And also, there's no correlation between a patient's ability to pay for a service or drug or on overall spending and actuarial value. Blue Cross's customers on the state exchange, and most of them outside the exchange, frankly, are in high deductible health plans with lower AVs. You can see here what the Blues approved rate increases on the state exchange have been for calendar year 23 through 25, and the projected spend for Blue Cross, according to GMCB, in calendar year 26. So if high deductible health plans and lower actuarial values and ever-increasing deductibles or copays was a solution to the affordability crisis, Blue Cross would not be on the edge of fiscal insolvency. It would not be struggling, as we are and everyone else is, with double-digit premium increases. There's also nothing in Bobby Joe's analysis that offers us insight into the percentage of what employees are earning today that is now being devoted to health insurance cost sharing. And that is a very significant amount of money at present. We believe that for our ESP, our support staff, they are spending now somewhere between 25 and 30% of their school income just to pay for the premium on their healthcare plans. I would also remind us, and I know we all know this, but I think it's important to say it because it can get lost in the numbers. Every claim is a person in need, not just a cost. The person's hardships, the person's needs, those should always be foremost for us. This is one of my favorite statements, and it's true in my estimation. Among all advanced industrial countries, the US goes furthest in using premiums, copays, and deductibles to influence access to care. Proponents argue that making patients have more skin in the game incentivizes them to stop purchasing unnecessary care and lower overall healthcare spending. It has never worked. It is time to put an end to this failed experiment. And as I noted in the document that I sent you, the 5-pager, when HSAs, health savings accounts, were sanctioned by Congress in 2003, and that was to drive the transition to high deductible health plans, or what became known as consumer-directed health plans, we were spending $1.3 trillion on healthcare in the United States. We are now approaching $5 trillion. So if the HDHP, consumer-directed health plan, HSA revolution was coming, It should have arrived by now. 2003, very famous study. Well, it's now famous. It wasn't famous in 2003. It's called It's the Price is Stupid. Why the United States is so different from other countries. One of the country's leading healthcare economists, Uwe Reinhardt, and a team of healthcare economists at Princeton and other universities published a study that concluded that the reason why the United States spends more on healthcare than other advanced industrial countries without providing more services is because of the higher prices of goods and services. This study was redone by the team in 2019 using 2015 and 2016 data. It was done in honor of Uwe Reinhardt, who died before the study was finished. It reached the same conclusions. The title, It's Still the Price is Stupid. The US was still not devoting more real resources to healthcare than most other OECD countries in 2015 or 2016. We have fewer hospital beds per capita, fewer practicing nurses, fewer practicing physicians per capita compared to our industrial I'm gonna say adversaries, they're not adversaries, competitors. So once again, the team reached the same conclusion. It's the prices. 2025, really fine, detailed article recently published in Healthcare Affairs. Health Affairs is one of the most distinguished journals, research journals in the United States. It reached the same conclusion. We spend more than peer countries because we do not regulate prices, and that prices are primarily responsible for the affordability crisis for employers and employees, not input costs, quality, or utilization, lack of price transparency, nor upcoding. And certainly vertical and horizontal consolidation within the healthcare industry has accelerated this trend. In our world, UVMMC is Vermont's mega provider. And as you can tell from the data that I have shared with you, both from the Green Mountain Care Board RBP analysis and also from Vermont Healthcare 911, we have the highest insurance costs in the country at present. And our mega provider is in the top decile with its outpatient costs. And most of those price costs are attributable to management and administrative costs, not patient labor costs. The fourth iteration, this is going to be just the fourth time we embark on benefit design in VEHI's history. And just a little bit of history lesson here. So from the late 70s to the mid 90s, before VEHI enters the scene, most school employees have something called the JYA and the JYB plan. There are others had Comp C, Comp D, Comp E. These were fundamentally, especially the JY plans, they were old style indemnity plans. To Bobby Joe's point, they had co-pays almost exclusively. Some of the comp plans had low deductibles. The JY plan, the JYA in particular, was beloved because it had the Y rider, which covered your first $200 of hospital costs in a calendar year. And for most of us who were starting out and teaching in the 70s and 80s and making no money, that first $200 was a godsend. And it covered primary care visits, specialty office visits. I tell you, it's the one way my wife and I kept our heads above water financially during those years. The Y rider is long gone. Now, mid 90s to 2017, VEHI enters the scene around 94, 95. We introduced the dual option plan. We maintain the JY. JY is different. It continues to evolve and go through some changes. VHP 300 comp, together known as the dual option, managed care product. They're the new kids on the block. We also will eventually offer our first high deductible plan a little later. For the life of me, I could not remember its name. But the lion's share of the membership by far was in the dual option, and most of them were in VHP. A very popular plan and still available for non-Medicare retirees in the retirement system. And then from 2018 to the present, we are in the plans that we have today for active employees and their dependents. You can see the monthly family premiums. I've got a lot of old documents in my files. You can see what a family plan cost monthly in FY80, like 45 years ago. And you can see its evolution since then in terms of price increases, premium-wise. For FY26, a family plan on the Gold CDHP will be $3,409 per month. I broke that out per annum. You can see the increase in the annual premium cost for a CDHP gold family tier coverage. For FY26, that's going to be $8,181. That's just the premium. Has nothing to do with the out-of-pocket cost. The out-of-pocket cost would only add to that. If we get a 10% premium rate increase in FY27, I have no idea what that rate increase is going to be. We would be looking at a family plan in the Gold CDHP of $37.50 and a per annum cost for employees at 20%. And these per annum costs are 20% of these monthly totals of $9,000 a year. So it's important to understand that from a school employee or school family's perspective, nobody thinks they're paying too little for healthcare. In fact, quite the opposite. There is a tremendous amount of disgruntlement and fear and anxiety about health insurance, just as there is among employers. And Vermont Healthcare 911 is certainly registering that. Premium contributions over the last 30 years have gone from 0% to 20%. Suzanne and Lisa will know from being negotiation veterans the days when there was no premium copay. And there was the Y rider. Again, those days are long behind us. And we have seen as these decades have rolled past that we have more and more services subject to out-of-pocket cost sharing. Also, as we think about healthcare design going forward, just take stock of where we are today in the market. Nothing looks like it did in the 1980s, in the 1990s when the dual option plan came along, and nothing even looks like it did, or very little looks like it did when we transitioned in 2018 or started planning for the transition to the new plans in 2015 and 2016. And we've gone over a lot of this. I have talked about it extensively in my written reports to you, but we are facing what I think is fairly described as an existential crisis in healthcare in Vermont. We have never faced anything like this in our tenure. The Act 167 report put it very bluntly. The platform for healthcare in Vermont has burned and requires rebuilding. And there's an urgent need to restructure care delivery at hospitals and save community-based care. Blue Cross of Vermont is too close to comfort for fiscal insolvency. It could fail. I hope that is not the case. I think it would be an apocalyptic scenario for the health insurance market as a whole, as well as for health, but it is not out of the question. Our federally qualified health centers, very, very financially fragile. We have significant provider shortages. 44% of Vermonters commercially insured between the ages of 18 and 64 were deemed underinsured in 2021. They had insurance, but they couldn't pay their bills. Underinsured. We're expecting a new Vermont household survey with updated numbers like this any day now. This is from a state of Vermont household health insurance survey. We have 62,000 Vermonters carrying medical debt, and the Vermont State Employee Medical Fund reported a $30 million hole this year. MVP and UVMMC abandoned the Medicare Advantage market. They lost $25 million. Blue Cross lost $43 million. Green Mountain Care Board predicts that Blue Cross will see another high rate increase in FY26, possibly near or even exceeding 20%. The Blues lost $64 million in 2024. I've talked about Vermont Healthcare 911. UVMMC's prices are among the highest in the nation. Green Mountain Care Board. For the very first time, our regulators are preparing to exercise rate setting and price capping authority in the RX world and also with reference-based pricing and hospital global budgets. The Trump administration is threatening severe cuts to Medicaid, which will be like a tsunami in this state and nationally. And the enhanced tax credits for qualified health plans on the state exchange are set to expire, which could also have very profound implications for the stability of the health insurance market and for those who are insured in it. One of the things that makes us really exceptional in
Hey,
health
Mark,
insurance.
Mark, I'm sorry to interrupt. You're 20 minutes in. We budgeted 20 minutes for this. I'd love to have time for board members to ask questions.
Okay, I will speed this up. American exceptionalism, we're buried in health insurance debt. While health insurance carriers make $1.356 trillion in earnings in 2023. 37% of adults, according to the Federal Reserve, report that they don't have enough money to cover a $400 emergency expense. Spending equals utilization in price. Bobby Joe and I agree on this. But when you parse out the prices, then you see a very different picture. Prices drive healthcare spending among people with employer-sponsored insurance. This is the conclusion of the Healthcare Cost Institute going back to 2002. They look at 1 billion employer-sponsored claims representing 50 million lives. They do 5-year rolling analyses of utilization and cost. I'm sharing this one with you because it was shared with the VEHI board in 2019 in a major study that we did for them, or a major report. What's interesting about this on the left-hand side, year over year and over the 5-year period, utilization decreased or it was the same. And look at the price line, again, on the left, for each of the major categories of care. Prices rose dramatically in each, but utilization stayed static or went down. International Federation of Health Plans, this is the power of regulation. Coronary bypass surgery in the US, $89,000. You can see the difference in Australia and in Spain, markedly less. The reason? High prices for services, medications, and admin expenses. And again, Americans face much higher out-of-pocket costs. This is for Bobby, Joe, John, and Chris, because we've been spending a lot of time talking about drugs and their costs. I'm going to talk a little bit about Ozempic, the weight reduction medication. You can see what it costs in the US. You can see what Humira costs in the US. And then you can see what it costs in competitive nations, industrial nations. Again, markedly less because these prices are regulated, not because they try to control these prices or utilization, I should say, to deductibles and copays. Green Mountain Care Board, the reason we have the 7th highest spending rate in the country, largely driven by the high prices of Vermont's commercial insurers. Whether we're looking at international data, national data, our own data, Green Mountain Care Board data, it's the prices. And this again explains why I have been so dogged, aggressively so even, but trying to move reference-based pricing, because there are literally tens of millions of dollars on the table, and they can begin to turn things around for us by setting rates or capping prices. This is our internal data. We've all seen it. Most of our members don't get a lot of health care. And those who do, their spending levels come in at rates well above any deductible threshold that we could set. Roughly 500 people drive $100 million in costs in 2023. That's 30% of our total spend. Most of our members, they do not get a lot of health care. Andrew Garland told us last week, there's a lot of sickness in our little state right now, and he's absolutely right. So yes, utilization is on the rise. I have never disputed that. We're not unique, though, in state, regionally, or nationally. I'll skip over this slide. This is just inpatient, outpatient visits on our hospitalization, just to show some of the variation that occurs from year to year. We will be digging into some of this utilization data in more detail with Blue Cross in the month to come. So before we proceed with any kind of benefit design costing out, my position is that we should not cost anything out yet until we have a real comprehensive plan of how we're going to proceed. A plan that agrees on principles, data quality and wellness metrics, pricing and cost transparency methodologies, and cost lowering, not cost shifting targets. When VEHI moved to the dual option plan in the mid-90s, they did so with the commitment of lowering premiums, and they did that by 10%. And they did not have to impose harsh cost shifting terms on employees. I want us to think about what it is we can do benefit-wise and in other realms of our work to actually lower premiums, or to set them at rates that are markedly lower inflation-wise than has been the case in recent years. That requires thinking, planning, and I think it also requires outside benefit design and consultative expertise, something akin to Remedy in the RX arena. We're still operating like it's the early 2000s, and it's not. We need to grow, change, become more sophisticated, and we need some help doing that. So let's develop, before we cost anything, a multifaceted plan for how we can transition to fewer and less costly benefit plans that offer comprehensive and more affordable coverage. And we leave collective bargaining and cost-sharing decisions to the parties that are charged with doing that under law, and for which it's their fundamental mission. I want to say a few things about Bobby Joe's copay plan. And Bobby Joe, I apologize. When I printed out your plan, I saw one, not two. So my apologies. I'm speaking to one of them, not both of them. The one that I saw, it's not exclusively a copay plan. It has deductibles in 6 categories for medical care, 1 tier for RX. However, what impressed me about it and what makes me think that the upcoming conversation between us could be very fruitful is that I think there's a recognition now that this HSA compatible, consumer directed, high deductible model, where every service has a deductible, it's no longer desirable or effective. Again, it's not lowered cost. The health reimbursement arrangements, the HSAs, those are not the reason we have an affordability crisis. It is the prices, and it's also who owns the health insurance industry and drives those prices. Removing deductibles for office visits, as Bobby Joe did, for primary and mental health care and most RX tiers, I think that's progressive. I think it's financially smart. And I also agree, of course, that we need fewer plans. Ideally, I'd like to explore moving to one plan. For education and administrative purposes alone, this would be highly beneficial. That may be a little premature, but it's certainly worth talking about. Thank you, Michael, for your patience. Happy to take any questions once I get out of this screen share.
Thank you, Mark. Questions for Mark? Cheryl?
I would like to be clear. I do not need to be convinced that prices are high. I don't need to be convinced that the state of Vermont has one of the highest prices in the country. I don't need to be convinced that we need to pursue reference-based pricing. I don't need to be convinced that we need to look into centers of excellence. I don't need to be convinced that we need to look at other vehicles similar to Remedy. I don't need to be convinced that we need to look into the telehealth services and primary care clinics. I agree with all of that. We need to do all of those things. We need to look at all of those things. But I also think we need to really look at plan design. And my principle for plan design would be looking at plan to design in the context of those we are asking to pay for the plans, not only employees, but employers, i.e. taxpayers. And when we talk about underserved Vermonters in terms of health insurance, those Vermonters have to pay their property tax bills. A great deal of that bill, in many cases, the greatest portion of their property tax bill is for education. And I think we have to keep that in mind. And so that I would propose as when we look at plan design, that is kind of the lens through which we're looking at it and considering. It's, let's think about the people, the other people, the taxpayers who are having to pay for this via their property taxes. And with regard to, I keep hearing about how much support staff have to pay for health insurance. And I've said this before, and I know it's not popular, but I'm going to say it anyway. Yeah, we very much appreciate the support staff that we have in the school. They do really hard jobs. They work with really difficult students. I can't imagine doing some of what they have to do on a daily basis in terms of dealing with students' bodily functions, you know, and on, you know, that's kind of the tip of the iceberg. They have so much to deal with. They do choose to take those jobs for a number of reasons. It allows, in a lot of cases, it allows them to work a schedule similar to the schedule of their children that they have at home, which means that they're working for 10 months and they're not working 40 hours. So in a lot of cases, they're getting a full-time 12-month benefit for working 10 months. And maybe, you know, I would say on average, the support staff in my district probably work like 35 to 37 and a half hours a week. So I just want to put that in perspective. I think a lot of them take the job because it does, we do have a great benefit, and that's great for those families, and that's part of their compensation plan, is that great benefit that they get. And yeah, if you look at how much they earn relative to what they pay, it is high, but there's another part of that that I think needs to be considered when that statistic is thrown out there. So I know I took up a lot, and I will zip it.
Thank you.
Thanks, Cheryl. Andrew?
So I was gonna probably say a lot of the same things Cheryl was saying. The only thing I would say different is that for me, it's not but, it's and. We have to look at both. You know, trying to look at plan design and look at what Mark's proposing. It's not one or the other. It's got to be both at the same time. And I know you were saying that, Cheryl. Like we got to do both, because I can tell you that every time I sit in negotiations and I hear teachers and support staff talk about, we need a raise because of the high cost of insurance. Well, it's costing the employer or the boards that much more. They're going up at the same rate. And then you go to your taxpayers, and your taxpayers don't want to, so it's actually pushing down salaries in, at least in my district, the cost of health insurance is pushing down salaries because we can't afford to keep going up and go to our taxpayers. I mean, we've been lucky. We have not lost a vote on a budget. I mean, I think the only time, twice my districts have lost, not in my tenure, but twice they've lost, and it was because they wanted to raise the costs, like because the board had it too low. So we've been very lucky, but every year we are getting scared now that we're not going to get a budget passed. And so if we go into double digits, which I know we're going to for health insurance, I'm probably going to be looking at laying off staff. That's just a reality. And so if we're not looking at how we can reduce everything on both sides of the coin, it's going to be a lose-lose.
Suzanne?
Thank you. So I'm a process person more than a product person, because I think we need to get the process right so we get the product we want. And this probably is going to be the most divisive issue that our board has faced in some time. And I would like for us to think about a way to figure out what's the process that's going to identify how we figure out our next step. And I don't have the whole process in my mind right now, but I started taking notes when people were talking about what their goals were. And I heard like affordability for taxpayers, affordability for boards, members. That was one big thing. I heard about keeping the system alive for everybody, whether it's Blue Cross or VEHI. I heard about the cost, what the total cost is. I heard about short-term fixes and long-term fixes. I heard a lot about simplification, that it's too confusing, that local administrative cost and time are out of control because there's too many options. I heard goals about optics. And so there's lots of things that are being thrown out there, and they're not always mutually exclusive goals, but I don't think we've established as a group, what do we want to do? Can we do it well? Can we think about a process? Whereas we all get to have our say and be happy, or at least be able to live with the outcomes we choose, because that's the deal with consensus. You don't have to like it, but you have to be able to live with it. And I'm feeling that it's an us-them discussion that could be happening unless we take the time that helps us figure out how we go ahead. So that's my long-winded speech, and I'll zip it to Cheryl.
Thank you, Suzanne, and I agree. And I think a process and guiding principles will help guide this board. One thought that I had during this meeting, and I'm sorry to spring it on Lance, was that we form a committee. You know, Suzanne and I got roped into a committee on the whatever that was, conflict of interest, right? So
Kumbaya.
yeah, so potentially asking two board members, one of the VSBA, one of the Vermont NEA, to go off and think about a proposal for I think, guiding principles and to bring it back to the board. So that's one way to do it, to make it a little more efficient rather than all of us on a board meeting doing it together. All right, it is 5:23. We're coming to the end of this, just the design, the plan design section. There's two motions that I'm going to look for, and then we can talk about the end of the meeting. The first motion is to authorize Lance and myself to educate the bargaining commissioners. Can I have a motion on that? Thank you, Lisa. Second. Thank you, Cheryl. Any discussion?
What is that gonna look like? Like what, when you say educate the commissioners, can you talk about that?
I think it's educate. Let me get the words right so that, and also so that we can get the motion right. So it authorizes Lance and Mike Fisher to have a conversation with the commissioners to ensure they understand the role of Blue Cross Blue Shield as an ASO, and to discuss our general thoughts on, the board's general thoughts on plan redesign.
Okay, and what are those general thoughts that we would be saying to them?
That we want to not be the negotiators. Like, I think that was generally clear. And that we're coming up with a design. We want to come up with a plan redesign and come up with some principles, including simplification, which was their ask.
Okay,
Mike, I would just say on the Blue Cross piece, there's the memo that Mark and Bobby Joe and I and Chris all collaborated on, which should make that job a lot easier.
Any other discussion? Okay. I'll call for a vote. All those in favor say aye. Aye.
Aye.
Aye.
Any opposed? Okay. It passes unanimously. Thank you. So the second motion is to authorize Bobby Joe to work with Blue Cross Blue Shield to price out the two proposed plans that she presented, and also to price out the legacy plans. Do I have that? Does anyone want to make that motion? Okay. All right, so that is the end of our plan redesign. And I think the takeaways are, we need to come up with a way that we're going to move forward with plan design. And maybe Lance and I, you and I can have a little discussion before May and bring a proposal back to the board, whether it's a committee or something else. It's 5:26. This meeting was planned to go until 5:30. We have not talked about the Blue Cross Blue Shield ASO contract, and we not talked about GLP-1s. So I'm curious, for the board members, what are your thoughts about extending this meeting or tabling those until May?
I have
The-
grandkids. I have grandkids here right now and I've pushed my limit.
Mike,
They're-
I could do
they're-
GLPs in about 2 minutes. If Bobby, Joe, and Mark don't object.
Any objection from the board to introduce this topic and then we can dive into it further in May?
That's fine.
Okay, go ahead, Jonathan.
So the spectrum for the GLP, which is the weight loss drugs, runs everywhere from, treated for diabetes, treated for weight loss. Now it's looking at heart issues. There's a whole gamut of stuff. It's costing us millions and millions of dollars. It's costing Blue Cross millions and millions of dollars. So Mark and Bobby Joe and I have been talking about it. It's just, we're trying to get our arms around what can we do? Where do we step into it? Where do we not step into it? But short answer is Blue Cross is also grappling with this themselves, and they need to make a decision before we need to make a decision. So what we're thinking is we let them roll out what they're going to roll out. We'll know it soon enough, as will the rest of the state. And we can then come back to you and say, here's what Blue Cross is doing. Here's what's happening in Vermont. Here's what we think we should or shouldn't do. That's my 2-minute speech.
It would be very helpful to me to know what's going on outside Vermont.
Okay.
Right? To know the trends of what's been going on with other plans, other insurance companies, how they handle it. That's number one. And number two, some data on who we're covering right now, who's using it. And if we make changes like to say, hey, we're only going to cover it if you've got a diagnosis of diabetes, what the impact would be in terms of the number of people who would lose coverage. So some data to help us understand the impact if we make any of those kinds of decisions.
Makes sense.
Figure all that
In
out.
fact, that's sort of what we're grappling with now. to be honest.
So much data.
Yeah.
Okay. So that's going to be on for May, GLP-1s and we'll go talk about the Blue Cross Blue Shield ASO. All right. So with that, any final thoughts before you adjourn?
Are we
Other
gonna
than
talk
that,
about
great.
the agenda for May?
So we can talk about the agenda for May, yes. So let me bring up the plan.
Is that the 20th, 3 to 6? Is that right? The May meeting?
Yes,
I just want to make sure I have it in my calendar right.
that is correct. Yep.
So we know if you can see the board's work plan. Can you guys see that?
Yeah, that's better.
Okay. So we've got financials, something strategic, setting Vister's rates, improving the auditor engagement, which I was told was quick. I thought we were going to talk an intro to the Visbit contract, which is up for the first time in a few years. Is that right, Jonathan?
Yeah.
Okay. And then the items that we talked about today, which is going back to reference-based pricing, going back to plan redesign, talking about the GLP-1s and talking about the ASO contract. So we'll talk, Lance and I and the leadership team will talk. I have a feeling we're going to need more than 2 hours.
It's actually scheduled for 3, so
There you go.
I don't know if we did it on purpose, but it is on there for 3 hours.
Questions or comments on the May meeting?
I guess I just want to say again, I'm very sincere about we need to kind of come at this from all directions. And I very much appreciate the list of items that Mark gave us. And we have heard a lot about reference-based pricing, and we're going to continue to look at that and get more information and work on that. and we're working on plan design as well. Are there some of these other items that he has listed that we should also start talking about? Telecare services, centers of excellence, primary care clinics, next generation PBM. You know, should we be adding those to our agenda as well in order to start going at this in multiple directions? Because maybe these other items aren't as big as reference-based pricing and plan design, but you know, it's clear that it takes some time to get us all to a point where we can make a decision and do something. And I think we should start adding these other items in if they're things we should be looking at.
Mark, you have a quick comment?
Yeah, I think most of those issues, Cheryl, would be part and parcel of a benefit design discussion. So if you had a center of excellence contract, for example, for knee surgeries or knee replacements, that would be built into the benefit design of the plan with particular cost sharing provisions as well. So most of those items, reference-based pricing to the side, although reference-based pricing could be a VEHI initiative as well. But putting that aside, most of those would be taken up in a benefit design planning process, I think.
Thank you. Any other comments on next month's meeting? All right, seeing none, I have a motion to adjourn. Thank you, Andrew. Second by Cheryl. All those in favor say aye.
Aye.
Aye. Opposed? All right, we are adjourned at 5:34. Thank you, everybody.
Thank
Lisa,
you.
Thank you.
children.
Bye-bye.